Welcome everyone to today's webinar, Rift Valley Fever in West Africa, One Health Perspective, hosted by SEED and the University of California, Davis Virus Intelligence Strategic Threat Assessment Program, or VISTA. As mentioned, I'm Angel Desai. I'm an associate professor in the Division of Infectious Diseases at UC Davis, affiliate faculty here at SEED, and principal investigator for VISTA, which is a risk-ranking framework supported by the Coalition for Epidemic Preparedness Innovations that aims to characterize the epidemic and pandemic potential of zoonotic viruses. As a reminder, some of our presenters will be speaking in English and some in French. To turn on captions translating to your preferred language, click the More icon with 3 dots at the bottom of your Zoom screen, then Show Captions. Then clicking the upward pointing arrow next to Show Captions, toggle Translation on. You will be prompted to select your caption language, and to view a full transcript of captions that you can scroll back through, click the arrow next to the CC Live Transcript button and select View Full Transcript to open a sidebar panel, and there should be instructions in the chat as well. To begin, as many of you know, Rift Valley fever virus is a zoonotic virus found semi-globally, associated with a wide range of mammalian hosts and carried by many arthropod vectors. Clinical presentation among humans can range from minimally symptomatic to more severe forms of disease, including meningoencephalitis or hemorrhagic fever. The virus has been highlighted as a priority pathogen by the World Health Organization's R&D Blueprint for Epidemics, as well as the International Pandemic Preparedness Secretariat's 100-Day Mission Scorecard. Preliminary data within VISTA suggest RVF and its family Phenuviridae rank highly among vector-borne diseases for its epidemic potential. Recently, a large-scale outbreak of cases of RVF was reported in Mauritania, the Gambia, and Senegal. And in today's webinar, we have an excellent expert panel who will be discussing various aspects related to this outbreak. Dr. Nicole Lurie is Executive Director of Preparedness and Response at CEPI and CEPI's US Director. She leads the team tasked with CEPI's operational approach to outbreak response, considering CEPI's preparedness investments in R&D and manufacturing to develop and deliver response and preparedness plans for CEPI's priority pathogens. Prior to joining CEPI, Dr. Lurie served an 8-year term as Assistant Secretary for Preparedness and Response, a presidentially appointed position at the U.S. Department of Health and Human Services. Dr. Mathorio is a veterinary epidemiologist and specialist in public health emergency management. Currently, he is the head of the Animal Health Protection Division at the Directorate of Veterinary Services in the Ministry of Livestock in Senegal. Dr. Moussa Diagne is a research scientist, virologist, and genomic expert at the Institut Pasteur de Dakar, where he leads the sequencing platform and serves as deputy head of the WHO Collaborating Center for Arboviruses and Viral Hemorrhagic Fevers within the virology department. In this capacity, he supports outbreak preparedness and response, providing reference laboratory services and genomic surveillance for WHO and regional partners, including Africa CDC and the West African West African Health Organization. Dr. Brian Bird is the director of the One Health Institute's Laboratory and Professor of Emerging and Zoonotic Diseases at UC Davis. Dr. Bird's work is focused on novel and known high-consequence viral zoonoses. He has an active research program in California, Sierra Leone, and Tanzania that involves both the animal and human health sectors, including virus discovery, virus host ecology, and the development of countermeasures ranging from vaccines to community-based risk mitigation and interventions. And finally, Dr. Britta Lassmann is an infectious diseases physician and health technology innovator with expertise in overseeing the development of applications at the intersection of clinical care, public health, analytics, and technology. At Boston University, she is a research associate professor in the School of Medicine and co-director and editor-in-chief of the Seeds Beacon program. So I'm going to start with Dr. Lassmann to give us a brief overview of Beacon and its role in reporting on the current outbreak.
Thank you so much, Angel. So thank you on behalf of CEED, the Center on Emerging Infectious Diseases based here at Boston University, for that introduction. The center is led by Nahid Badelia and focuses on bringing together multidisciplinary researchers as well as policymakers to respond, educate, and train in the area of emerging infectious diseases. One of the programs here at SEED is Beacon, the Biothreats Emergence Analysis and Communication Network. It's a new program, open access, that was launched in April 2025 and focuses on using event-based disease surveillance, so picking up signals from around the world from media, social media, news media, blogs, and other sources to rapidly and transparently report on emerging infectious disease events. And we have actually picked up the signal on the Rift Valley fever outbreak in Senegal back in September 2025 and have been reporting on that and documenting the evolution and geographic spread into neighboring countries, as well as covering it from like a One Health perspective, focused on not only human cases, but also on cases in livestock in that region as well. So over to you, Angel, for starting the webinar. Thank you.
Thank you, Dr. Lassmann. Each panelist will now have a few minutes to discuss their perspectives on RVF and this outbreak. We'll start with Dr. Lurie. Thank you.
Hey, everybody. It's a delight to be here with all of you. I thought I might just add a little bit of context here, because as you know, we are funders of Beacon and VISTA and are really big supporters of this because we get early signals about an outbreak response. But I just want to back up a little bit and say that, for those of you who are not familiar with CEPI, CEPI is an international organization that develops vaccines for potentially epidemic diseases. And in the first, since CEPI's inception, we have focused in large part on viruses and diseases prioritized by the WHO blueprint. We're now shifting to a viral family approach and working on diseases that are in a viral family, again, which involves and continues to involve Rift. But with that, we've been working with VISTA, particularly to help us understand, well, which viral families are most likely to cause human disease and potential, spillovers and human disease and ultimately bad epidemics or pandemics. And then to think about how do we best develop prototype vaccines for viruses in that viral family. In this case, we don't have to do that for Rift because Rift is already a prototype vaccine. And as you'll hear from Brian, we have a portfolio, and there's a whole bunch of Rift vaccines in the making. But just to give you a sense about how this works, if we get a signal, first of all, we have prioritized viral families according to the VISTA spillover risk, as well as to consider the priorities on different continents, particularly Africa, Latin America, and parts of Asia. If we get a signal from Beacon, which monitors now outbreaks around the world, we look first to say, is this a pathogen that is in our current portfolio or a viral family with a disease X that is in a viral family we prioritize? And then we look to see what could happen. In this case, we first saw a signal about a Rift Valley fever outbreak from Beacon. And because Rift has been one of our priority pathogens, we have kept very close track of the development of those vaccines and knew immediately that there were candidate vaccines in clinical trials that were able to, if desired, could be further both tested in the context of an outbreak and potentially used to provide benefit to controlling an outbreak. And so we look to see how that might move forward. In this case, what was terrific is that we were in touch with folks at IPD Dakar within about 6 or 8 hours of our learning about the outbreak, and heard very quickly from their director of public health, Dr. So, and others, that they really were interested in moving forward with a vaccine response. It turned out, however, that there was only one vaccine candidate at the time that really had the potential to make available doses for vaccine trial, and that also was far enough in development that people felt as though they could advance development in a clinical trial during an outbreak and potentially provide some benefit. And that was the Oxford's Chadox vaccine. Turned out that at the time, all of the doses of the Chadox vaccine were dedicated to an ongoing phase 2 trial in Kenya, which was a 2-dose trial, and they were in the process of second dosing their participants. So we had a conversation with Serum Institute of India, who manufactures a lot of the Chadox vaccines, and they agreed to try to advance with us the 100-day mission and to see how fast they could emergency manufacture doses of vaccine. It turned out that they were able to emergency manufacture drug substance much faster than any of us thought, in about 14 days. But then vials started, coming off the production line. But after that, there's been a process of lot release, which has also taken some time. So we are now continuing to work with IPT Senegal to move forward now with the vaccine trial. As you'll hear, I think from Dr. Diagne and others, the outbreak for right now is about over, but we need to be poised so that the next time there's an outbreak anywhere on the continent, we're going to be able to move forward. And to that end, we are planning a sort of a small safety run-in with this new vaccine so that there are no questions when we start, that we are ready to go forward safely with a vaccine trial. So that's how this process works for us. Thought I would share that with you, and I'll wait for questions or comments later. Thanks.
Thanks, Dr. Lurie. We're going to move now to Dr. Fall.
Good afternoon, everybody. I think I will talk in French. I'm sorry for my camera, but I don't know what happened to my camera. Donc, je vais très rapidement parler en tout cas français, et je vais commencer d'abord par vous remercier de nous avoir associés par rapport à ce webinaire, qui est en tout cas très, très intéressant. Et puis, c'est vraiment un plaisir en tout cas de pouvoir partager en tout cas les quelques expériences que nous avons eues par rapport à l'épidémie de la fièvre de la vallée du Rift ici au Sénégal. Peut-être juste rappeler que l'épidémie a démarré en tout cas au mois de septembre, le 22 septembre 2025, donc avec une confirmation au niveau des humains dans le nord du Sénégal. Donc c'est d'ailleurs la région qui est la plus touchée de l'épidémie. Et à ce jour, en tout cas, on a totalisé 561 cas positifs et 31 décès chez les animaux, chez les humains, mais également on a eu des cas chez les animaux. Et à ce jour, on est à 446 cas positifs chez les animaux, avec plus de 2026 avortements qui ont été notifiés. Et à ce jour également, il y a 12 régions qui sont touchées sur les 14 régions du Sénégal. Donc, vous voyez que pratiquement tout le pays était touché par l'épidémie. Il faut signaler également que la fièvre de la vallée du Rift, elle est endémique au Sénégal. Donc, le ministère en charge de l'agriculture et de l'élevage avait fait une enquête de séroprévalence nationale qui a montré que le virus circulait pratiquement dans toutes les régions du Sénégal, avec une prédominance de la prévalence au nord et au nord-est du pays. Et il faut se rappeler également qu'on a eu des flambées, en tout cas, de la fièvre de la vallée du Rift. On a eu des flambées, en tout cas, en 2020, 2022 et en 2025. Donc, ça montre vraiment un cycle qui vient tous les 2 ou même les 3 ans. Mais la particularité, en tout cas, de cette épidémie en 2025 se mesure par, en tout cas, plus de régions qui sont touchées dans le pays. Le nombre de cas confirmés est très élevé chez les animaux et chez les humains. Nous avons également enregistré pratiquement des décès chez les humains, plus de 31 décès. En tout cas, il y a plusieurs facteurs en tout cas, qui ont contribué à ce que cette épidémie puisse prendre des ampleurs et que cette épidémie a également des impacts. On peut citer en tout cas certains facteurs qui ont amplifié cette année l'épidémie. Il y a les fortes pluies de cette année, en tout cas au Sénégal, parce que cette année, vraiment, il a beaucoup plu au Sénégal. Les pluies qu'on a enregistrées cette année, on ne l'a jamais en tout cas enregistré au Sénégal. Donc, il y avait vraiment des très fortes pluies. Ensuite, nous avons vraiment une densité vectorielle qui était énorme. Donc, il y avait vraiment beaucoup de vecteurs au niveau de ces régions qui ont enregistré des cas. Il y avait également un autre aspect, c'est l'environnement très favorable pour le développement des gîtes larvaires, notamment les déchets, les ordures, l'eau stagnante, les marigots, etc. Vraiment, il y avait toutes les conditions favorables pour permettre en tout cas un développement important de ces vecteurs. Et ceci vraiment a contribué à une explosion des nombres de cas. Et il ne faut pas également oublier la mobilité animale, parce qu'au Sénégal, il y a ce qu'on appelle la transhumance. Et là où il y avait les premiers foyers, là où il y avait l'épicentre de la maladie, c'est-à-dire la région de Saint-Louis, les animaux font la transhumance. Et ils vont aller vers le nord, le nord-est et le centre. Et cet aspect également a contribué à la propagation également de la maladie dans les autres régions. Et je vais terminer également par l'aspect également du virus que les gens ont fait un génotypage, mais on s'est rendu compte que le virus, en tout cas, il se multiplie beaucoup plus rapidement. La réplication, elle était très rapide par rapport, en tout cas, aux précédentes épidémies. Je pense que j'ai fait, en tout cas, le tour par rapport au premier point. Je ne sais pas si je poursuis par rapport au second point, par rapport aux mesures qu'on avait prises pour l'approche Une seule santé, parce que pour gérer l'épidémie également, nous avions pris des mesures selon l'approche Une seule santé pour pouvoir en tout cas contrôler la maladie aussi bien en santé animale qu'en santé humaine. Et parmi ces mesures, en tout cas, il faut se dire qu'il y a en tout cas la réunion au plus haut niveau du pays avec les autorités, en tout cas qui ont été sensibilisées par rapport à la fièvre de la vallée du Rift, à ses impacts. Et également, je vous rappelle qu'au Sénégal, nous avons le Haut Conseil national sur la sécurité sanitaire mondiale One Health, qui avait vraiment joué un rôle important de leadership par rapport à la gestion de cette épidémie. Et il faut se dire que en s'activant cela, on avait mis en place aussi le système de gestion des incidents avec une approche Une seule santé, avec tous les sectoriels, le ministère de l'élevage, le ministère de la Santé, le ministère de l'Environnement et tous les autres ministères sectoriels, en tout cas, qu'on a géré l'épidémie selon une approche Une seule santé. Cette structure est mise en place au niveau central, mais également au niveau déconcentré. C'est la même structure qui est mise en place et qui permet de coordonner, selon l'approche Une seule santé, en tout cas, la gestion de cette épidémie. Et si je dis qu'on a réussi, c'est parce qu'il y avait cette collaboration multisectorielle avec l'implication de tous les secteurs, mais également la mise en place de ce système de gestion des incidents selon l'approche Une seule santé qui a permis une coordination vraiment optimale au niveau central, mais également au niveau déconcentré. Voici en tout cas sur les quelques points que je voulais en tout cas accentuer mon intervention. Et je reste en tout cas à l'écoute s'il y a des questions ou bien s'il y a des compléments d'information. Merci beaucoup à vous.
Thank you so much, Dr. Fall. We'll move now to Dr. Diagne.
Thank you very much, and good morning, everybody. So I will try to share my screen right now. Okay, perfect. Thank you very much, and thank you very much to everybody for this opportunity. And I would like to thank Boston University for covering this important discussion, and also the Center of Emerging Infectious Diseases and One Health Institute at UC Davis through this VISTA program. And I think it's very important to have this cross-disciplinary discussion about this really harmful outbreak of rift valley fever and to discuss about the different conclusions. So quickly, I will just move on the lab perspective and just quickly introduce IPD, Institut Pasteur de Dakar. It's a century-old institution. We have adopted a kind of integrated surveillance. So we have a different platform like the genomic platform, the diagnostic innovation, capacity building approaches. Then what we are doing now is a way to strengthen the genomic surveillance in Senegal and West Africa, but also somehow in Africa. We have also a kind of listen to communities approach and One Health observatories that are also implemented in some part of the country. And we are also deploying some sensors to support environmental surveillance. So this is just a breakdown of what we have found last year in 2025 in terms of arboviruses, except dengue and Rift Valley fever in the 14 region, just to show that the big deal were only mainly dengue and Rift Valley fever. For dengue, we had like more than 1,000 cases in the countries, and for Rift Valley fever, I will just show you the results. So just to show here that before the implementation of our syndromic surveillance system in Senegal, we were only able to detect some few cases of both Rift Valley fever and Crimean Congo, that are two hemorrhagic fever viruses. But after the 4S installation, which is a syndromic surveillance system in Senegal, which is coordinated by both Ministry of Health and Institut Pasteur de Dakar, we are now able to identify more cases. So meaning that we are able to identify even the cases that was not visible in the past. So in the same way that we are organizing a syndromic surveillance system, we are now in a phase of lab decentralization. So we are trying to move to move a lab close to the patients. So in August 2024, we have implemented the first lab in Touba, which is the second biggest city in the country. And more we have established other labs in Kédougou, for instance, in Saint-Louis, in Ziguinchor. And right before the implementation of after the implementation of the Saint-Louis lab, we were able to identify the first Rift Valley fever in 2025. It was in September, and it triggered the outbreak response by the Ministry of Health, and as it was mentioned by my colleague Mathorio, by the country. And we're able to implement different labs, even a mobile lab truck in a remote area like Matam, as you can see in the country. So in blue, you can see the region supported by IPD during this outbreak. And here is the staff that were deployed in the lab staff. So in blue, you have people that are permanent. So they are like permanent in the different region. And in red, the people that were deployed for the outbreak response. So you can see that in area like Kaolack, we didn't have any reference lab for that. And we just deployed people for this outbreak. While in Dakar or in Kédougou, in Touba, we have already people that were already permanent lab staff that were used for the outbreak response. This is a kind of overview of the lab activities, but just to summarize that, we have almost 20,000 samples that was tested during this outbreak. We have, as it was mentioned by my colleague Mathorio, 560 positive cases, and we have like mosquitoes that was also tested. We have 24 mosquito pools that were positive among more than 2,000 pools obtained in the fields. And we're able to also get some few animal samples, a part of what was done by the veterinary lab called ELNERV in Senegal, where we were able to find 4 RT-PCR samples. This is another, sorry, this one is in French because it's directly from the dashboard, but to show it started in 8th of December, we were almost like 5% of people that passed away after the infection, unfortunately. And the sex ratio was 1.8, and the median in terms of people infected was 26 years old. And as it was mentioned by my colleague Mathorio, most of the cases are the northern part of the country. Even though we are able to find some cases in other part of the region of Senegal. And the same one here, just to show the percentage of death, more death in Saint-Louis, and mainly because it was during the beginning of the outbreak. But after the implementation of a lab and all the countermeasures, we were able to reduce the death rate. This one is basically to show the specific symptoms and to show that now we have the outbreak is declining, and we are almost at we are definitely at the end of this one. And the main symptom was syphilis, myalgia, and asthenia among others. And in terms of genomic surveillance, so far we are able to sequence 91. Now it's more than that. We are analyzing 300 additional samples, genome, sorry. But at that time, it was almost more than 60% of confirmed cases that were sequenced. It's more than the cutoff requested by WHO and Africa CDC during an outbreak, which is 8%. And we were able to identify the lineage that was responsible for this outbreak. And we also confirmed the interspecies transmission between human, mosquito, and ruminants using this genomic approach. And 3 key mutations was observed in 3 different segments: the L segment with the D11N, the M segment with the K1111R mutation, and the S segment with the R137K mutation. But only one of those 3 mutations was non-conservative, that can induce a potential impact in terms of fitness. It was the one in the L segment. That can induce it, that can impact the viral replication efficiency, as it was mentioned also by my colleague Mathorio. And then we are still studying the impact of this mutation in our lab. So, but hopefully we realize that there is no compromising mutation in epitopes targeted by vaccine countermeasures. So this is really a good news. But during this outbreak, interestingly, we are able to identify the co-circulation of this major epidemic H lineage, but also a minor variant. It was basically 4 cases in 2 regions. So we had like 2 circulation, the co-circulation of the major lineage and H, and another strain from the same lineage circulating at the same time. And here, briefly, we are able to do a kind of phylogeography analysis showing that Saint-Louis was the main hotspot of the outbreak. Of course, we have a high frequency of outbound transmission. Multiple flows were from Saint-Louis to other regions like Muluga, Matam, Dakar, the capital city, and Fatick. And what was interesting, Dakar, the capital city, was only the place where for reception of strain rather than retransmission to other areas. So we are able to identify almost 75 transmission chain during this outbreak, and we are still working on the analysis with our new genomes. But just to show that the number of occurrences in terms of migration and the impact of human and ruminant and mosquito on the transmission of this virus during this outbreak. So just to make a quick conclusion, we have seen that the pattern shows that there is an initial outbreak centered on Saint-Louis, of course, and we have a gradual spread to several regions of the country. The decentralized lab had a significant impact because we're able to reduce the turnaround time until 5 hours between sample collection to the delivery of the first results. And we faced some challenges. Among other, we have like insufficient sample volumes, so incomplete or eligible epidemic clinical forms, the compliance in terms of cold chain requirement, or some lab tubes that were not identified correctly. So this is some few issues that we're facing during this outbreak, but I would like to thank you, and I will be more than happy to answer to any additional question. Over.
Thank you so much, Dr. Diagne. Finally, Dr. Bird, I'll move to you.
Thank you, everyone. It's glad to be here with you. Let me see if I can sort out the screen share. One moment. Share, I think. Again, thanks everybody. It's wonderful to be here to talk about Rift Valley fever and really appreciate the updates we just heard from Dr. Diagne and Fall on the outbreak in Senegal. And really, my hat is off to you in the laboratory space for doing a really incredible investigation. I'm really very much impressed with that. So my role here is to talk about countermeasures and where we stand in the current state of play across vaccines and other potential countermeasures. So there's some approaches and challenges, and I was asked to present on the sort of global landscape here, and I want to make sure it's very clear. As Dr. Lurie mentioned, I'm one of the leads of a program to develop a vaccine candidate for humans with support from CEPI called DDVax, which we'll talk about just briefly in a minute. So I just want to make sure that's very clear to everyone. Okay. And thanks to Dr. Hart for sharing this table up above on the top of this slide. This is he presented in a recent meeting in Nairobi, funded by CEPI, talking about the regulatory space for vaccines and vaccines approvals. But when you think about human vaccines, there's been a lot of research done over, well, quite honestly, since the very beginning and recognition of Rift Valley fever. So Rift was first discovered or reported in the early 30s, and the first vaccine for Rift was actually developed in 1936. So people have been aware very early on that Rift was an important medical issue that needed to have some type of countermeasure. So the current state of play in human vaccines, there are 4 candidates being funded by CEPI currently. All have very promising profiles, either in preclinical or early clinical stage trials in humans. You have 2 live attenuated candidates, the Larissa 2 project led by Wageningen University in the Netherlands, and then our project here at UC Davis, DDVax. These are both live attenuated viral constructs, attenuated in different methods and different ways, but the end result is quite similar. Larissa has phase 1 completed, and they're planned to start phase 2 quite soon in Eastern Africa. For DDVax, we are on the cusp of starting our phase 1 trials early part of this year. ChAdOx, as Dr. Lurie mentioned, sponsored by University of Oxford and their platform technology, the adenoviral vectored vaccine. They've completed their phase 1, and they're now well into the second dose of phase 2 completed in Kenya. There's also mRNA candidates being supported by CEPI, a company called Afrigen in South Africa. They're in the preclinical stages right now with eventual phase 1 plans in South Africa there. And then there are other vaccines. As I mentioned, vaccines have been worked on for many, many decades for Rift Valley fever. A lot of this effort led by the United States Army, Department of Defense. You have 2 candidates, MP12, live attenuated vaccine, and then the original formalin inactivated vaccine that I have received, and probably others on this call have received at different times over different outbreaks across Africa. So that's the vaccine landscape. So several in clinical trials, some coming up soon, and then other more historical vaccines with quite a bit of data supporting the platforms. So when you look at other types of countermeasures, so emergency response or post-exposure prophylaxis, thinking about monoclonal antibodies or antiviral drug compounds, the landscape is quite deep. There's been a tremendous amount of preclinical development in this space over many years. And to my knowledge, thus far, we could only find one example of a monoclonal antibody that's currently in a clinical stage study. And this is a PK study led by ID Biologics for a monoclonal antibody cocktail for Rift. So that's sort of the state of play. There are vaccines coming, as Dr. Lurie mentioned. There was quite an interest to try to get vaccine interventions in the face of the Senegal outbreak. And didn't quite happen at the highest peak of the outbreak, but hopefully some of that work can get going here as the outbreak's tailing off. So just a couple slides on DDVax, and then I'm going to focus more on the challenges that the vaccine landscape faces. So DDVax, as I mentioned, live attenuated vaccine construct that myself and others, the US CDC, helped invent or create right after the East Africa outbreak in 2006, 2007. And we took an approach of removing the virulence factors from the virus, and then eventually realized that this could be a potential vaccine candidate. And there's been a whole series of scientific work evaluating safety profiles, other scientific attributes of this kind of construct. And we found some interesting things in the science of the virus. Not only are some of these genes that we removed, virulence factors, but they're also important factors for transmission in the mosquito. Some actual just basic science development work there as well. For DDVax, we've had a really long development history. DDVax was originally thought, and we pursued it as a livestock vaccine. More on that in a second, in this integrated One Health approach for control of Rift Valley fever. So we've tested in a wide variety of animal species, both adult animals, young animals, pregnant livestock, pregnant rodents, you name it, we've tested in a preclinical space. But what's most exciting to me is we're now moving very rapidly into our phase 1 safety trials to be conducted in partnership with IFICAR Health Institute as part of a large consortia of efforts that's been funded by CEPI the last several years, led by myself here at UC Davis, but other partners, IFICAR Health Institute in Tanzania, as I mentioned, Colorado State University and their manufacturing partner, Biomark. Key inputs from our colleagues at the University of Pittsburgh for immunological and other laboratory diagnostics, CRO, IQVIA, and then our own UC Davis Health Clinical and Translational Science Department here. So this trial will get kicked off hopefully end of Q1, early part of Q2, 2026, conducted here at the IFICAR Health Institute's clinical trial facility in Bagamoyo, which is on the Indian Ocean coast of Tanzania, just up from Dar es Salaam, if you're familiar with the country. So for the challenges, I put this in here, not to read every word here, but to impress upon you that there are lots of words and arrows and other gobbledygook here. The life cycle and epidemic causation ecology of Rift Valley fever outbreaks is incredibly complex. It really spans the true spectrum of One Health, including the environment, climate change influences on heavy rainfall, the way vectors are involved, the initial emergence of transovarially infected mosquitoes that then feed on livestock that then in some way transfer the virus into the human population, either by direct mosquito bite or through direct contact with dead and dying livestock, as Dr. Diagne mentioned, or perhaps it's Dr. Fall. Huge numbers of abortions and dead livestock in Senegal as part of this outbreak, and that's very typical for classical Rift Valley fever outbreak scenarios. So just to say, the ecology is very complex, and that really influences the challenges in developing vaccines. So the technology for vaccines can be developed. These are solvable technological questions. There are several different platforms under development right now, the live attenuateds, ChAdOx, vectored vaccines, other vectored vaccines, and then mRNAs and any other type of approach you could want to take. Those have technical challenges, but they're technically resolvable. I think to move vaccines, regardless of the platform, and I'm speaking as a scientist interested in Rift Valley fever and the prevention of disease, not a vaccine developer per se, but just someone who wants vaccine candidates to be on the shelf for Rift Valley fever, we have some challenges. The key one is, how will you use a vaccine if you can make it and get it approved? Who should get it? And this is a table from a publication from my group that's in press right now. You'll see it out in a few weeks, I would guess. But we go through this step by step of what vaccines are most appropriate for different use case scenarios. Are you doing routine prevention and prophylaxis in a general population? Are you targeting only high-risk individuals, abattoir workers, livestock keepers because of the zoonotic transmission? Are you only focusing on outbreak response? Are you trying to do something different? And then key in that is, how do you measure the efficacy of these vaccines? Rift Valley fever outbreaks occur periodically. There are climactic factors that are involved, and programs like Beacon are working to try to see these signals and get it refined down so that we could say, okay, they're very, very likely an outbreak coming. Can we marshal our resources to get outbreak clinical trials in place before all the cases have gone? Because Rift Valley fever outbreaks don't tend to last incredibly long periods of time. They tend to come and go as the vector population comes and goes. So efficacy assessment is extremely difficult. You do that during outbreaks. How do you measure breakthrough cases in face of outbreaks? Is it real-time PCR testing, IgM antibodies? Just lots of questions there. Should we rely on alternative pathways for licensure, things like the animal rule and things of that nature? And then another level deeper than that is what's the community acceptance of Rift Valley fever countermeasures at all? This is a disease that we know scientifically is present in many places continuously. Like, yes, there are large outbreaks, but we've shown quite convincingly, I think, in Tanzania and other colleagues in Uganda and in other places that there is endemic or hyperendemic transmission of the disease. So how do you work with populations and communities to recognize, yes, there is a problem and there should be something done about that, even if you have the technology on the shelf ready to go? So my group, we've done an extensive amount of community engagement in Tanzania with community stakeholders, livestock keepers, and the like, trying to understand the social behavioral factors that would go into people being aware of Rift Valley fever, aware of it enough to recognize that it is a bona fide health threat, even if there's not an outbreak going on actively, and what would be key factors that would allow them to enable Rift Valley fever vaccine use in their communities. So that's some of the key challenges from my perspective. And I just want to thank CEPI and others who've worked on the vaccine project from my side, the DDVax and others over the years. So thank you very much for that. And with that, I will stop my share and hand it back to Dr. Desai.
Thanks so much, Dr. Burden. Thank you to all the panelists for that really illuminating discussion. Before we open it up for a Q&A with the broader audience, I'd just like to follow up with a couple of questions for the panelists. Starting with Dr. Lurie, how does CEPI evaluate the potential impact of RVF investments on outbreaks?
So it's a great question. So I think what we really want to do in CEPI's goal is to have vaccines ready for potentially epidemic vaccines that can be used to protect a population and keep an outbreak from becoming an epidemic and an epidemic from becoming a pandemic. One of the reasons that we focus on the viral families is because we know that these vaccines can also mutate over time and become much more contagious than they are now and much more deadly than they are now. So we focus a lot also on what we would call Rift X, a much worse version of Rift that we want to have a vaccine for. But I think in terms of evaluating our own investments, we are really focused on investments that get us to a vaccine, preferably a licensed vaccine or something that could be used under emergency use authorization if there were a bad outbreak. Now, to do this, obviously, you can't, just as Brian said, focus on vaccine development, but you have to think about the One Health aspects of this, which are sort of outside of CEPI's remit, but you have to think about diagnostics, you have to think about the epidemiology, you have to think about the clinical characterization of the disease and the immunology of the disease. And right now we're supporting some studies, including in Senegal, to look at how we collect data that could get us to a correlate of protection so that we could have an alternative pathway to licensure. So I think that's the other way in which we do it. We know that it takes about 9 starts to get to a licensed vaccine. And so for our portfolio, as you've heard from Brian, we've got a bunch of different candidates in our portfolio with the goal that 1 or 2 of them would make it to license or emergency authorization. I should also say that because equitable access is a huge focus for CEPI, and because post-COVID, I think we all appreciate the need for vaccine manufacturing on the African continent. We're also really looking at how vaccines could be tech transferred or developed on the continent for use on the continent. And that's another evaluation factor, I think, in our vaccine portfolio.
That's great. Thank you so much. It actually sets us up well for my question for Dr. Falla, just thinking about sort of this One Health perspective. What are some potential, and you mentioned a few, but what are some other potential One Health focused interventions that have been or perhaps should be employed during this outbreak?
Merci beaucoup. En tout cas, comme je l'ai dit tantôt dans mon intervention, donc par rapport à l'épidémie de la fièvre de la vallée du Rift, je disais que l'approche Une Seule Santé, en tout cas, a joué un rôle essentiel. Parce que dès le départ, nous, on a compris que pour gérer cette épidémie, il faut qu'il y ait en tout cas une approche une seule santé. Et on a en tout cas fait le focus sur la coordination parce que il y avait plusieurs secteurs qui devaient intervenir. Tout à l'heure, j'avais dit qu'il y a la santé animale, il y a le ministère de l'Agriculture et de l'Élevage, il y a, il y a les parcs nationaux, il y a l'eau et l'assainissement. Donc, il y avait plusieurs intervenants. Et pour coordonner ces activités, il a fallu en tout cas l'approche une seule santé. Et je pense qu'au Sénégal, on avait en tout cas, comme je l'ai dit tout à l'heure, le Haut Conseil national sur la sécurité sanitaire mondiale, ONHEF, la plateforme qui est vraiment la coordination politique. Et c'est logé au niveau de la primature. Nous avions également la coordination opérationnelle, donc comme je l'ai dit, avec le système de gestion des incidents, selon rapproche une seule santé, où on avait pratiquement tous les acteurs qui interviennent au niveau national, mais également au niveau local. Et dans mon intervention tout à l'heure également, j'avais dit que de la même manière où on a mis cette coordination multisectorielle au niveau national, dans toutes les régions, nous avons la même structuration, nous avons la même coordination au niveau local. Et ce qui a beaucoup marché, c'est surtout l'installation des systèmes de gestion des incidents qui a permis en tout cas une coordination parfaite pour l'ensemble des sectoriels. Si je prends l'exemple de Saint-Louis, là où l'épidémie a commencé, ou la région qui est la plus touchée, ce système a été mis en place sous le leadership du gouverneur de la région. Le gouverneur de la région, à son tour, en tout cas avec tous les sectoriels qui étaient impliqués, notamment le ministère de l'élevage, le ministère en tout cas de la santé, les eaux et forêts, les parcs nationaux, mais également les acteurs qui interviennent dans la lutte. Donc, en tout cas, ce qui a beaucoup marché, c'est surtout en tout cas cette coordination multisectorielle qui a permis à l'ensemble des acteurs de coordonner et de collaborer. Et si je prends l'exemple pratique par rapport aux interventions sur le terrain, ça veut dire que si dans un village, nous avons la confirmation, qu'il soit chez les animaux ou bien chez les humains, d'un cas de fièvre de la vallée du Rift, il y a l'équipe multisectorielle qui part sur le terrain. Toute l'équipe part sur le terrain. Et ce qu'on fait, c'est qu'au niveau de la santé animale, on prend les mesures, notamment on fait la vaccination périfocale, on fait le traitement en utilisant les répulsifs pour le vectoriel. Ensuite, la santé humaine également fait une recette active des cas. Ils vont faire des prélèvements sur les personnes. On distribue des moustiquaires en même temps. On fait la lutte antivectorielle. On détruit les gîtes larvaires. Et les services d'hygiène également désinfectent les lieux en même temps. Et également, les spécialistes de la communication font la sensibilisation. Donc, vous voyez, c'est plusieurs acteurs qui interviennent en même temps. Et ceci vraiment a rendu efficaces les interventions parce que ce n'est pas seulement un seul secteur qui part pour résoudre le problème, mais c'est plusieurs secteurs, c'est plusieurs acteurs qui agissent en même temps en faisant des opérations coup de poing avec le package d'intervention sur le même lieu. Et ceci vraiment a permis en tout cas de régler rapidement les foyers, de permettre rapidement en tout cas de détecter les cas au sein de la population, aussi bien chez les animaux que chez les humains, mais également de prendre les mesures en tout cas de lutte efficace pour pouvoir stopper la maladie. Mais en tout cas, le mot-clé, c'était l'approche une seule santé. C'était la coordination entre les différents sectoriels qui a permis en tout cas de bien gérer cette épidémie. Merci beaucoup à vous.
Thank you, Dr. Fall. That was a really excellent discussion. Dr. Diagne, you presented some really beautiful slides looking at genomic surveillance in the context of the current outbreak. I wonder if you could speak a bit to the role of genomic surveillance in elucidating not only the current outbreak, but also other outbreaks in the region, in your experience.
Thank you very much. I think that I would say it's today from a One Health and preparedness perspective. Genomic surveillance was really essential to move from detection to understanding and action. So for this outbreak, by sequencing those complete Rift Valley fever genome, we've showed that the outbreak was driven by a single epidemic lineage. We have shown that we have a lineage that was circulating across humans, vectors, ruminants. So we confirmed an interconnected animal-human transmission system rather than isolated events. So this one with the phylogeographic analysis was really important information to help stakeholders and different parties to have the correct actions for the response to tackle this outbreak and then reduce the spread to several regions. So it helped to prioritize interventions across sectors, including, like it was said by my colleague Mathorio, animal health, vector control, human surveillance. It was really important. And also, as it was said by Professor Ball, vaccination is really important. And with this genomic surveillance, we are able to say that, okay, don't have any mutations that affect known vaccine epitopes. This is really important in terms of information from risk assessment and preparedness in a way that we can plan better rather than triggering unnecessary concern. So it was really important for this outbreak. And it was the same situation for Ebola. For Ebola in DRC, where I was in 2019 and 2018 and 2019, we used the same tools to support the epidemiologist team for the transmission chain tracking. And we were able to mention that, okay, guys, you missed probably one case because you have noticed that we have more mutation in the sample X compared to the sample Y. And then you may have like another cases in the same region. And at the end of the day, it was really critical to support the response for the transmission chain tracking, but also for the diagnostic efficiency, because we are able to see to identify any potential erosion of diagnostic, because we have like viruses, that we have a fast evolution of those viruses, and we are able to identify if our current diagnostic tools are efficient against those pathogens. And so we have so many examples on how this genomic surveillance is important for our clinical, in a clinical perspective, but also for diagnostic and the lab, and also in terms of epidemiologic transmission chain. So yeah, I will stop here, but we have so many examples on how genomic surveillance can be of interest.
That's fantastic. Thank you so much. Thank you. And we'll just finish up with Dr. Bird. You you talked a little bit about some of the challenges with regards to the ecology surrounding RVF in the development of a vaccine. I wonder if you could speak a little bit more in depth about unique challenges with regards to vaccine development or deployment for this virus and pathogen.
Yeah, thanks for the question. Well, I think one of the biggest challenges is in the deployment. So let's assume we get to a licensed vaccine product for humans. There are existing vaccines for livestock already, and there are people working to improve those every day. So I think Rift Valley fever is the prototype, really, I think, for a zoonotic disease and potential One Health countermeasures. So thinking about deployment of human vaccines to is it the high-risk groups, so the people with really direct contact with livestock or animal products, and then integrating that at the community level with widespread vaccines for livestock and vector control, right? So I think for Rift Valley fever, it is different than the Ebola context, which I have a little experience with. There is an outbreak that is direct, typically human-to-human transmission change, as Dr. Diagne just mentioned, where molecular epidemiology is critical in tracking these down, and the missed links, as you rightly pointed out, right? Rift, it's rained a lot in a lot of places. There are lots of mosquitoes. There is lots of transmission. And I think now with the work that they've done in Senegal, you can see that, yeah, the virus is tracking either with movement of people or livestock to different places, new places in the outbreak scenario chain, right? So how do we get out in front of that, right, in real time? So Rift Valley fever is a disease you chase. You chase it around the map, right? Ebola also opened our eyes to that in West Africa, right? That it moved beyond the typical outbreaks that have been kind of geographically constrained in the past, right? So the deployment of vaccines, I think, is going to be an interesting challenge because we can build it. Some are built. We can use them, but we will be able to use them effectively to really have a public health impact. That's my kind of worry, honestly, in the whole vaccine space, because Rift is an easy vaccine target in theory. It's one serotype. The genome, doesn't change a huge amount over time. It does, yes, but it's not a dengue scenario where there's 4 different major almost species of virus out there that you have to tackle. So there's lots of unique advantages to vaccine countermeasures for Rift, but some real challenges when you get into the societal level implementation of them. And I think that's, to me, the most interesting questions that we need to work on. And it's the most, I think, rewarding for the community when we can start to solve those issues moving forward. We're close. I think, next 10 years is going to be a really exciting time for this space in deployment. Over.
Thank you so much. And thanks to all of you. I think we may actually be at time. So we may be able to take one very short question. If there's anybody, you can use the chat button real quick. And if not, that's great too. I'd really like to just take a moment to thank again all of the panelists for this really fantastic, very timely discussion. Really appreciate it. And to the audience and participants, thank you so much for your attention. And I hope everyone has a great day. Thanks so much.